So today's case is about a persistent cough in a 10-year-old, which caused a recurrent pneumonia. What kind of things could have caused this situation? Mom comes in with the chief complaint. My daughter seems to be sick all the time. She's been coughing for several months. Her cough has sounded very harsh and productive. I've given her many over-the-counter cough and cold medications, but they don't help. I've also taken her to see her pediatrician, and she has had 2 rounds of antibiotics for 2 episodes of recurrent pneumonia. Amoxicillin was the first and augmentin the second one. She seems to feel better after she's done with the antibiotic, but within a week or two, she's back to the same fevers and bad cough. She has no known medical issues. She's had a normal weight and height, so it seems like she's growing fine. Normal birth and delivery, there was nothing going on at that time, and there's no family history of lung disorders in our family. On physical exam, her temperature is 101.7. She has a heart rate of 100, a respiratory rate of 25, blood pressure of 100/72. On HEE and T exam, all is clear. There's nothing obvious that would point to something acutely respiratory. Lungs, however, show an easy work of breathing, but with left-sided crackles and decreased breath sounds to the left, lower lobe. Her abdomen is soft. She has no guarding. Her heart exam is all normal. She's warm and well perfused. Extremities show nothing of note, and neurologically, she's grossly intact. Now, what kind of considerations of diagnosis should we think about in someone presenting with a recurrent and persistent cough? Based on our most likely diagnosis, what do you think should be your next steps in management? In terms of our differential diagnosis, a recurrent cough can most of the time be caused by exposures, especially for school-age children that are exposed many times throughout the year to viral illnesses. The differential also includes a pneumonia, rarely mediastinal masses, foreign bodies, more so in the infants and younger age groups and toddlers, because they specifically like to put things in their mouth and sometimes things can get lodged, or in someone that could have had foreign body aspiration because they're compromised in some way. They're not able to control their airway on their own. Someone with chronic illness, for example. It could be a pulmonary malformation, immunodeficiency syndrome, or asthma-related cough and flare-ups that can cause one to have recurrent cough symptoms. Now, what are some clues? She's had a normal weight and height. She has no chronic medical conditions, no family history of anything of note, such as autoimmune diseases or illnesses. The lung trouble seems to be persistently on the left side, and she's had multiple episodes of pneumonia. On test results, she has an increased white count, a little bit over, of 12,000. Her CRP is elevated. Blood cultures are negative. BMP is normal. Chest X-ray shows an opacity to the left lower lobe. She did get some pulmonary function testing, and that was abnormal. PPD testing is negative, so it doesn't seem like she's had any tuberculosis exposures. And a CT scan of her chest shows a left lower lobe abscess. Now, these test results, of course, were not done within the office. She was actually taken in for further exam once she presented to the pediatrician, and the pediatrician was concerned with her recurrent pneumonias. So this is where the further workup occurred. So her diagnosis and the assessment and management part of our case. Recurrent pneumonia due to pulmonary sequestration. Now, this is not common, and we'll go into the detail about that in a little bit. She was admitted for inpatient management of pneumonia and for IV administration of antibiotics. She was put on cefuroxime and azithromycin. She was found to have no other chronic illnesses upon study. Now, What exactly is a pulmonary sequestration? We'll get into. But on her chest X-ray, it showed patchy airspace densities that involved the left lower lobe. In this example on our chest X-ray, the opacity is on the right side. But this just gives you an example of how the chest X-ray may present in someone with issues caused from pulmonary sequestration. So when a patient presents with a lingering cough that lasts for more than 3 weeks, the most common reasons are not usually rare. And some examples, of course, as we mentioned, are viral illnesses, especially in school-age children. You could also have allergens such as dust, pet dander, or chemical exposures. Irritation to the throat from reflux disease or asthma-related flare-ups. Those are the most common. In pulmonary sequestration, this is a condition where an area of non-functioning lung tissue, which we would call dysplastic, is residing with no connection to the rest of the tracheobronchial tree. It actually receives its own systemic vascular supply, often from a major artery, and it does not function as a unit with the rest of the normal lung. And this can then predispose one to recurrent infections from this end of the lung area, such as pneumonias, abscesses, and so forth. Now, some keys to remember. Most of the time in children, the cough is not serious and you can often treat with home remedies. It's often at times recurrent throughout the year, especially if they're at school or exposed, and that's actually normal for children to have several respiratory illnesses throughout the year. But we want to look at what is the severity of these respiratory illnesses. Did it lead us to have to treat with antibiotics? Did we find anything suspicious on their exam, or was it just cough and cold related symptoms? That would be okay, and you could use things such as honey as long as they're above a year old. You can do other soothing remedies. You can do warmth, of course. You can have the child be right next to a humidifier that can help to increase some moisture in the air. You can put on the shower and have them to stand in the bath or sit down just to get some of that warm air going into the lungs, which can often be soothing. You want to avoid using cough suppressants in children because the body is designed to cough in order to relieve any irritant within the lung. So if you are suppressing the cough, you're potentially leading to mucus buildup and inflammation, which we don't want. So we really don't want to suppress a cough. We would rather want to relieve one of the mucus that's there to get rid of the congestion. So I avoid those things altogether. If a cough persists and is not getting better with standard measures, then you want to, of course, investigate further because that wouldn't be normal. Only use imaging modalities when you need to so that you don't expose children to unnecessary radiation exposure. Never underestimate a good physical exam and the history, as this will often give you clues. Don't hesitate, however, to do a full workup if you need to. If someone's coming in with recurrent lung infections, it's localized, and the progression of their illness just doesn't seem right for what you're treating, go ahead and do a full workup. If you'd like to hear more about how to manage cough, recurrent pneumonia, and some of the differential diagnoses that we mentioned and more, then definitely go ahead to the Teachable website where you can find a deeper look for the upcoming course. See you soon.